I want to thank Dr. Jumian and Carr for the opportunity and privilege to present here today, and I'm going to pick up on some of the things that Dr. Wu discussed. This is a complex topic, and in just a short amount of time, I'm going to try to make some high points and give you some take-homes to learn about. Here are my disclosures. So we heard this morning that shock is really about timing, substrate, and team, and I'm going to try to address the issues related to substrate and a little bit about timing. We know that blood homeostasis really relates to the balance seen in Virchow's triad in terms of flow, coagulability of the blood, and the surface. If we think about the surface in shock, we have chaos. We have issues in terms of the foreign implant material, in terms of many elements related to chemistry. We also have a constantly changing surface as the timing of this continues to change. And then we have the implantation of these other additional devices, which complicates that. We heard a lot about surface area. There is a nonlinear relationship between the length and surface area in terms of activation. So just to roll through this quickly, you see on the bottom axis from even old work that things start to happen very quickly on a surface. You have competition between cells and protein elements. And what happens is you've got abundant materials that deposit on a surface, which then are competed by other materials which have a greater avidity for the surface. So you've got pro-adhesive and anti-adhesive proteins that have a battle. This is called the Vroman effect, that then certain things ultimately win. There is a contact activation on the surface with things related to high molecular weight kininogen and kallikrein. We don't even measure this stuff, yet that's highly active because it activates factor 12, and factor 12 interacts with the intrinsic cascade. I will tell you on the horizon with Merck and others are new anti-12 drugs that may have impact for devices as well. Somebody asked, is there a counter-regulatory process going on? Yes, there is, and that's a whole other hour lecture, which we won't get into, but there's a CARS response which balances the intrinsic response that occurs due to the new foreign device. Let's move to flow. We heard that, sure, flow is normally pulsatile. The advantage of pulsatile flow is it allows relaminarization of flow and greater flow. But in continuous flow devices, whether small like Impel or beyond, you get very high shear. And if you have an obstruction or any element in the flow, you're going to get a super high shear, and we call this superphysiologic shear. Years ago, I wrote about a balance which exists between normal and hypershear. You need normal shear for normal endothelial cell function. That's why we were talking with Dr. Smalling this morning about those issues. So what happens in shock is this change of the shape of an equilateral triangle to being really an obtuse type triangle. You initially with shock have a greater hypercoagulability and stasis, and then you pop in a device, and all of a sudden you've got this hypershear and increased progressive coagulability, which changes over time. The numbers are astronomical. You heard there are about 1,000 dynes as opposed to normal blood flow, which can be up to 10 or 30 dynes per centimeter squared. This then affects normal mechanisms in the blood. Von Willebrand factor, you heard about GP1B, that's the normal way that with shear thrombosis occurs. But that's not really happening because VWF is blown out in this hypershear condition. So what our lab has been about has been the demonstration that you can activate cells in the free flow. You don't need any of this. It's just moving through these high-speed devices. We've got an emulation of this. We basically have a wind tunnel for cells in our lab, and we've been able to demonstrate that there's a progressive activation of cells over time. But here's an interesting, cool experiment. We took platelets, exposed them to the same absolute level of shear, but changed the rate of loading of that shear, which can happen with different devices. And net, you get higher levels of activation with the same absolute level of exposure. So the way you get there matters, and that brings in a new concept called stress accumulation. It's the intensity times time and the process that leads to this. I'm not going to kill anybody with math here, but basically intensity plus rate plus accumulation is the individual risk. Until we can calculate this on an individual basis, we're going to be heterogeneous, and that's why we see very different responses. Here is a single platelet, just to show you response. One platelet exposed to different levels of activation, of circulation around, and you can see progressive pseudopod extension. And then if you continue this, you then generate microparticles, and that's a whole other hour discussion because they are prothrombotic. So platelets are shear sensitive, they accumulate shear stress, there's a threshold, the total dose matters, and frequency components matter. Then you've got the heart, loaded with thrombus, and that this is also prothrombotic as well. And we have just published this. This came out 3 days ago on this process that we can predict from the math what actually happens in the clinic. I don't have time to really get into it. Please, it's public access. Read the paper. Then you add fibrinogen. Eddie asked about CRP. Let's add fibrinogen. And fibrinogen levels go up. You add fibrinogen to the hypershear, and bingo, it gets even worse. So you have to realize that prothrombosis and antithrombosis, like a chemical engineer, there's a mass balance thing going on. Net is zero, but one goes up, one goes down. And that's what's going on. You've got prothrombosis leading to antithrombosis, prothrombosis constantly going on, and we don't have any way to measure that. So in today's world, whether it's acute VAD or chronic VAD, we think that the VADs are better, but what's actually happening is downstream, we're creating a lot of activation as it moves through the pump. And we've also demonstrated that hemolysis, published recently, is a driver of thrombosis by itself in terms of the membrane driving the intrinsic pathway. Now, can we squelch it with drugs? Quick answer, no. We published over the last 2 years, aspirin doesn't work. Bottom line, it works at low shear, but it doesn't work at high shear. And now we've looked at all the agents, and none of them work. I'll click through this very quickly. Prosanthine, forget it. Pentoxyphylline, forget it. Integralin, forget it. Combinations, they don't work. Yet, low shear, they work great. Chew your bare aspirin if you're having a heart attack. Dipyridamole works great. Integralin works great. Pentox, great. Why? As you increase the shear load, you start generating microparticles, and you dump them, and they are highly prothrombotic. But you also dump 2B3A. Guess what? So that when you then give an agonist, shown here, they don't activate. So the same platelets that are driving thrombosis distally also don't work if you have bleeding, so that's why you have a nightmare with these patients. We've also just published, this is about to be published in Blood, a signature. So for the first time, we can differentiate out shear activation versus biochemical activation with different markers. Phosphatidylserine goes up, thrombin goes up. It's not the standard stuff, and we need to get to this level of granularity to deal with this. How about reality in patients? We did a large study in San Raffaele with colleagues in Milan, 68 patients, and we were able to demonstrate that our platelet activation marker of annexin and phosphatidylserine works. If you see it elevated beforehand, you're going to have a pump problem, and it will remain up until you remove that device. So we've described a lot about what these mechanisms are. I encourage you to read this paper. We'll make these available. And there are a lot of things going on. There's a dynamic balance between the procoagulant and bleeding effects. It's a multidimensional problem. So let me conclude. Blood contacting devices have caused us to redefine Virchow's triad to hypershear in the free flow. Shear activation is super complicated with a lot of things, and we don't measure any of this stuff today. In MCS patients, we really have to look at these individual components. Until we get to that, we're not going to be able to really affect this. Current drugs don't work. There's a distinct phenotype. And I have to thank the NIH for funding. And I have 3 seconds left. Thank you very much.
Dr. Slepian, I have 2 questions for you.
Sure.
How many slides?
That was about, I don't know, 45 slides.
Yeah. In 8 minutes. Well done. Second question's a real question. So if this is about activation and an extension of the activation of the platelets, has anybody tried any immunotherapy?
No, but that would be a good thing. And what I didn't get into at all is the paper, the last thing I talked about was the concept of, so we have activation. All of us as clinicians, whether we're cardiologists or surgeons, we give all the antiplatelet drugs. They don't work. Some way the platelets are getting activated. Our big point is that there's mechanoactivation beyond biochemical. So we need to modulate the mechanoactivation. How do we do that? We've coined this concept of mechanoceuticals. We were nice enough to get this big grant by the NIH. And what a mechanoceutical is an agent which changes the mechanical properties of the cell without acting as a secondary messenger biochemically. I'll give you a concrete example. If we change the fluidity of the platelet membrane just a little bit, it doesn't activate. Think about it. If you've got a rigid body and you have a force, you have coupling. But if you make that body a little bit more elastomeric, it bounces off. So just by modulating a little bit the platelet membrane process, we can make a difference. How do we do this? With lipids. So we're looking into a whole range of lipids that can do that. Also stiffness. We've shown that if you change the stiffness of the cell, it doesn't activate as much. So that potentially is a way to deal with that. Now, immunotherapy might be interesting as far as dropping the immunoload that secondarily, like the fibrinogen thing, affects platelets. Whether it'll work directly on the platelet to be determined. I'll also tell you that young platelets behave very differently than old platelets. And you know, it's a whole world. I mean, sometime in the future, I hope I have an opportunity to be back, give you 1 hour or beyond on this, because it's a really deep problem. But that's a great question. Thank you.
Are there any
Yeah,
I'm just-
the
if you didn't
question's
hear.
about genomic studies. So people are starting to look at that. They're doing platelet proteomics today to take a look at this. You know, we have a multi-scale model of platelets that we've published on that looks at all these membranes. I mean, if you unfurl the platelet, it's basically like a rolled up flag, and you unfurl it, you've got all of this mountain of membrane, and what does that do, and how does that change? And what we've identified is that there are regional hotspots in platelet membranes that may make a difference, and how do we modulate those? It's pretty complicated. Since devices are not going away, we have to deal with this. You know, and drug pathways are complicated. We went through this lipid strategy because potentially we could use a nutraceutical. So we actually tested fish oil to see if it worked. Answer, doesn't work. So Nir Uriel published a nice paper. I couldn't put that in. I talked about it previously on bleeding, and he's shown that you have a slightly lower bleeding rate. And you know why? We act because those fatty acids activate platelets. So it's a difficult thing. You may help on the bleeding side, but you're also making it prothrombotic chronically for the VAD. You know, he was talking about acquired von Willebrand. Complicated Scylla and Charybdis balance that you've got going on here, and it's tricky. Until we have the way to monitor this, the last thing I'll say, we have point-of-care assays that we're working on in small microfluidic chips. I couldn't cover all that. And the idea that you could monitor that and monitor some of these other variables might give you an online perspective of what's going on, what's going down. You have a VAD patient, they get an infected foot, all of a sudden you have a shift in your von Willebrand, in your Virchow's triad, and you've got to modulate for that because they're highly prothrombotic. We don't change anything that we do, and we don't even have the right drugs to do it. But those are the things that are going on. That's what we have to do to advance this field. So, question?
I think we're about 8 minutes ahead. Do you want to show another 45 slides?
Yeah, I have.
Jim, please.
Yes. Oh, we have a question.
No.
Go ahead. Question and question. Go ahead.
Can you tell me about mechanoactivation and the shear you talked about regarding the speeds of the valve? So higher shear?
It's really about shear. It's stress accumulation. So it's intensity of shear times time of exposure. So and why that makes a difference is because not every single platelet, you have to think about this like chemical engineering again. You have a body of platelets. Some of them get chewed up. Some of them get consumed. Some of them are in the spleen. But some of them keep coming back out. So, you know, if you have bleeding, you know, we also dump a lot of platelets from demargination and other mechanisms and other things like white cells. We don't have a contractile spleen like an animal, but still, young platelets can be even more sensitive. So all this is going on. But it's the intensity times time, not just the speed. You know, it's like a centrifuge. You don't just look at the speed, you look at the G-force. So here you look at the shear force. You had a question.
Have you used I saw the slide that you have with the antiplatelet medications, and
Yeah.
they didn't do the
Right.
inhibition. Have you used Plavix?
Yeah, very good pickup. Plavix doesn't work. Prasugrel doesn't work. The one that has a little hint of work, and I presented this at the last ISHLT, is ticagrelor. So, but you know, for me to tell the surgeons, you got to put everybody on Brilinta, they'll have a heart attack. You know, and I actually think that the future might be a tad bit of Brilinta and a tad bit of a anti-10A. And I know what we've done those studies with rivaroxaban and all that, but we didn't get the dose right. You know, that may be a better strategy.
I mean, my point is the following. When I was in med school, I was a tutor for pathophysiology, and we did a sepsis platelet aggregation. And we tried everything, and the only medication that works was Plavix. And as you said, we sent a paper to Germany. We did with these rats. When I became a surgeon, my thesis to graduate in Venezuela was about sepsis in rat. We were creating a ligation and puncture,
Sure.
giving Plavix to this rat, and the survival improved.
The thienopyridines have some potential. Plavix by itself under the high shear doesn't work. Here's an important point for everybody to take home. There's a process. There's platelet activation, and then there's aggregation. What I told you about fish oil, Take your fish oil. Fish oil for normal people blocks aggregation. But if you have a VAD put in and now you've got this jet engine driving shear, it will not block upstream activation. So there it's bad. But for everybody else, anti-aggregatory effects are good. So we have to separate out aggregation versus activation. And activation is a different thing, because why activation matters, it's not so much whether platelets aggregate. They don't necessarily have to aggregate. If you don't get a little white clot like an upstream MI, you have an active surface. And here's the thing, I threw that out of the slides. The platelet membrane is the key, because on that, the 10A complex forms. 10A, 9, and 5 form a molecular machine only recently described in terms of the stereochemistry, and prothrombin comes in and thrombin comes out. So even if you don't drive bulk with platelet aggregation, you'll have an activated surface, which is going to drive the thrombotic side, where you need anticoagulants. The words get fluffed up here. There's antiplatelets. They're all antithrombotics. Then there's antiplatelets, and then there are anticoagulants. So you may be driving, the anticoagulant path, or the coagulant pathway, and that's the thing that we don't separate out. We don't measure this stuff. Who uses platelet activation studies in their routinely? They don't. And why? Because you got to run to the lab. Platelet aggregation is a pain in the neck. You got to spin the blood down. You get artifacts. We're actually working on a point of care single drop aggregometer that we've developed. Again, I can't do this in 5 minutes, but there's a lot of potential for science to improve the coagulation status as we move forward. And then if we really add the inflammation of shock, which is a whole other thing, and if somebody comes in that's been down and you have crush and you have other things, then you've got a whole other biochemical mix. We have to be able to tease this apart.
Among the determinants of shear, I mean, viscosity of blood is also playing a role.
Right.
Is there a way to manipulate this factor if
Could
we are
be.
not able to manipulate the platelet itself?
Could be, absolutely. I mean, if you really found that your viscosity was way up, you might give more of a crystalloid, that. On the other hand, these patients, albumin, I didn't even ask about albumin yesterday, but, on the renal side, that's a whole thing. You've got an oncotic balance, that's an issue, so you potentially might do that. The analogy I'll give you, if we go to that route, it's like going back to specific gravity in the urine, which we don't ask the resident anymore, what's the specific gravity of the urine. They're trying to give us our FINA, or whatever. But I mean, simple things like that may be very, very valuable. But we're not, that would be good. So, one more.
Just a quick question. Could you comment on the development of shear stress with the three, different commercially available VADs, HeartMate 2, HeartMate 3, and
I showed it in a microsecond on that slide. We truly do see that in the HeartMate 3, the level of platelet activation based on our PASS assay, which is a thrombin generation assay, is the lowest. So kudos, and we have worked, and actually the paper that I showed you, it's now public, that what we just published was actually, we worked with Abbott, what was then Thortec, on HeartMate X, which has not come out and will not come out, but we looked at, could we optimize it using this strategy? So on the other hand, I will not say it's not perfect, because while the gap size may be better, if you've got a problem upstream or downstream, you may blow through it. Like somebody said, they had a fish go through the pump and it was fine. But if that fish goes downstream and it lodges in your brain, you're going to have a stroke. So HeartMate 3 is clearly better, but none of the systems are perfect. And then the last point I would make is it's a system. I didn't get into that. You may make the pump perfect. That's sort of what that slide was about. But if the angle of implant is bad, if the cannula angle is bad, if the circulation direction is off, you are adding elements to this. You can't look at this like stent thrombosis, a single little thing. It's a system-based thrombosis that occurs, and any one of these things can go wrong. Thank you very much.